Good afternoon, everyone. I'll go ahead and do the roll call. Dr. Curran, Mr. Halpert, Major General Carden, Dr. Cheek,
Present.
Dr. Shin,
Present.
Dr. White,
Present.
Dr. Cole,
Present.
Dr. Mercer.
Present.
Thank you. Myself. That's the board member roll call has been accounted for. You all received the board minutes from the last meeting for your review. Just like to submit those for a motion for approval. Dr. Curran, if you'd like.
Motion, we approve.
Okay.
About a second.
All in favor?
Aye.
Thank you. Curran, the list of attendees has been accounted for and the minutes are approved. I'll pass it back to you. Thank you, sir.
Thank you, Mitch. I think we're going right ahead to, I believe, Megan Andrews proceed. Dr. Drensick, is that right?
Yes, that's right. All right, I will go ahead and get started with a session update for you all. We wrapped up Monday last week, so I'm still in recovery mode because it was definitely a late night, but there's a lot for me to go over with you. I'm just going to give you a high-level overview of some of the legislation we were tracking and working on that has potential impact for public health. So as I mentioned at the last board meeting, this session was unusually busy for public health. Comparing this session to session 2 years ago, because we run on a biennial schedule, we were tracking 192 bills this year as opposed to 186 last year. And these are any bills that could have either a direct impact on public health operations or maybe of interest to the programs that are housed within DPH. More so, the change between the 2 years is on the number of direct impact bills. So this year we had 189 of those bills were considered direct impact, meaning we anticipated either the start of a new program, changes to our operations, increased caseloads, things of that nature are qualified as direct impact bills. So we had 89 of those this year as opposed to 43 2 years ago. So we were quite busy this year. We had to testify on several pieces of legislation throughout the process. You can go to the next slide, Frederick. So I'm going to give you a quick update on our 4 agency bills from this year. We had childhood lead poisoning. That bill did receive final passage. We are awaiting governor's signature on all of these bills that passed. The second one is EMS wrap back. And I'm going to go over each of these in more detail about what the bills actually do on the next slides. EMS wrap back did also pass. The Smoke-Free Air Act and the inclusion of vaping did not pass. It was not called up for a vote in the Senate on sine die, so they simply ran out of time through that last day of session. And then the Filming Patients in Healthcare Facilities bill did receive final passage. You can go to the next slide, Frederick. Thank you. So the childhood lead poisoning bill, House Bill 1355, was sponsored by Representative Katie Dempsey. It did receive final passage at 12:05 a.m. on the last day of session. It was, I believe, the third to last bill that the House took up. So we got in right in the nick of time on that one receiving final passage. This bill brings Georgia law into compliance with CDC recommendations as far as when public health intervention should take place for childhood lead poisoning. So it updates the definition of confirmed lead poisoning from 20 to 3.5 micrograms of lead per deciliter of blood. It also updates the definition of lead hazards in order to align Georgia law with EPA regulations on this matter. And then also 1.8 million was included in the budget that received final passage and that's to fund for additional lead inspectors throughout the public health districts and equipment for them to do risk assessments in the homes of lead poisoned children. Will Bell is going to go into a more in-depth update on the budget for your next meeting, but the budget is still waiting for governor's signature, but I did want to let you know that that funding was included and it was tied to the passage of this legislation. You can go to the next slide. So the Smoke-Free Air Act and Vaping Bill, as I mentioned, it was not called up for a vote in the Senate on the last day of session. It was on their agenda, but they ran out of time to call it up. What that bill would do is update the current Smoke-Free Air Act to treat vaping the same as traditional tobacco smoking. So right now, under Georgia law, vaping is still permitted in enclosed spaces. For example, restaurants, daycare centers, government buildings, et cetera, that prohibit traditional tobacco smoke. Under Georgia law, vaping is not prohibited in those spaces. So this bill was seeking to bring parity between traditional cigarette smoking, tobacco smoking, and vaping in Georgia law. So we are hoping to work on that again next year. It did pass the House committee, the full House, as well as Senate committee. So it did have a lot of support. It was sponsored by Representative Bonnie Rich from Gwinnett County. You can go to the next slide. The third agency bill is our EMS fingerprinting bill. That one passed and is awaiting the governor's signature. It was sponsored by Senator John Alvers. Currently, our EMS licensees do submit for fingerprinting for a criminal background check when they are licensed by DPH. However, DPH is not notified after their initial licensure if something pops up on their background check. So if they have a criminal violation that occurs after initial licensure, we are not updated unless the licensee updates us, which they're supposed to do, but sometimes tend to forget. So this bill allows us to participate in a federal program that's run by GBI and FBI called RAPBAC. So GBI would retain the licensee's fingerprints and then notify us of any criminal violations that occur after initial licensure. You can go to the next slide. And then the final agency bill that received final passage was sponsored by Senator Bo Hatchett. We ran into some challenges in the past, I would say, year and a half. It's happened on at least 2 occasions where members of the public have come onto county health department property and recorded on their phones patients coming in for services or the waiting rooms of our facilities where patients are waiting for clinical services like our Ryan White clinics or waiting for their vaccination or family planning services. So what this bill does is makes it a criminal offense to record patients in county health departments without their consent. There are certain exceptions in law already for things like security cameras by the facility owner or things of that nature, but it will help us protect our patients that we serve in these facilities. You can go to the next slide. So I talked about the direct impact bills. There were 89 that we were tracking. Here is a list of those that received final passage. And I am doing in the next slides, I'm doing a high level summary for you of what some of them do. The ones that I think you may be most interested in, not all of them, but you can go to the next slide. So the Mental Health Parity Act, House Bill 1013, I'm sure you've seen this in the news. This was one of Speaker Rustin's priorities, and there was a huge effort among the advocacy community and legislators to work on bringing mental health parity to Georgia. It's a comprehensive mental health reform. DPH does have some involvement in this space. There's 2 teams that we'll be serving on to look at needs for disabled infants, children, and youth, and then another team called Match to look at resources and solutions for unmet needs of children in this state. So we'll be involved in implementation, at least in those 2 teams, and have a seat at the table due to our work with children. Next slide. The next bill that passed is raw milk sales in Georgia. That's House Bill 1175. That bill did receive final passage and is awaiting the governor's signature. It authorizes the production and sale of raw milk for human consumption in Georgia. It was changed from the initial version that was introduced to narrow the scope, so it only applies to direct-to-consumer sales of the product. So you won't be able to purchase raw milk at, say, a grocery store or a gas station or things of that nature. It's direct from the dairy to the consumer. An amendment was added on the Senate floor as well, related to testing of synthetic opioids. So it declassifies testing equipment that's used to determine if a synthetic opioid is in a product as a drug-related object. So it's no longer, those are no longer considered drug-related objects for criminal law purposes. You can go to the next slide. Audiology screening updates were also received final passage and is awaiting the governor's signature. Under current law, only individuals who are not licensed audiologists cannot use autoacoustic emissions or auditory brainstem response technology for anyone over 3 months of age or older. So this bill would expand the scope of folks that unlicensed individuals can test for. So it'll go up to age 22. Right now, it's just age 3 months, which the focus of that is really the hearing screening that occurs in the hospital setting for newborns. So we are anticipating increased access to hearing screenings for our youth population with the passage of this legislation. Next one. House Bill 1443 is a change to the way that we license food trucks in Georgia. So currently, food trucks have to be permitted and inspected in each county in which they operate. This bill would allow, once a food truck is permitted and inspected in one county, they would be authorized to operate in any county in Georgia. Outside counties do have the ability to still do surprise inspections of those mobile food trucks while they're in that they call it outside county. We do anticipate a fiscal impact to DPH for implementing this for various IT upgrades. This was not funded in the budget. The estimated costs are about $245,000. Most of it is one-time cost for IT upgrades, but there's a little bit of maintenance and operations that we're gonna have to seek funding for. Next one. This bill it's been floating around for a couple years, and it finally received final passage one of the last days of session this year. It's the HIV modernization bill. It modernizes the HIV laws in Georgia to bring it into align with science and ensure a current understanding of best public health practices. So that bill is still awaiting governor's signature. Next. Senate Bill 345 did also receive final passage. This bill prohibits state and local governments from mandating vaccine passports for the COVID-19 vaccine. Private businesses are not included in this, so they may still implement COVID-19 vaccine mandates or require passports. Through the legislative process, an exception was also added for entities that are required by CMS or any federal contracts that they've entered into to check COVID-19 vaccination status. Next slide. This bill, maternal autopsy, stemmed from recommendations from our Maternal Mortality Review Committee. Really, two of the top recommendations were legislation or funding was included for them this year. One was the postpartum Medicaid extension to a full year from the current 6 months. And then the second one is this maternal autopsy bill. It does require a medical examiner's inquiry to be conducted whenever there's a death of a pregnant female or an individual who was pregnant within 1 year of the date of their death. There is an exception that this requirement doesn't apply if the death is from an accidental cause, like a car accident, or it's apparent that the death was not related to the pregnancy. Funding was also included in the budget for DPH's implementation of this requirement of $150,000. The intention is for those funds to be provided to regional perinatal centers that are going to be conducting these autopsies. Next. The Unmasked Georgia Students Act also received final passage and was signed by the governor. This is one of the governor's bills that he was working on this session. It prohibits school boards, school superintendents, administrators, teachers, or any school personnel from making or enforcing a rule requiring masks while on school property, unless there is an option for a parent to exempt their student from that requirement. This law does not apply to any public health administrative orders related to masking for things like tuberculosis, exiting quarantine or isolation early, etc. Next slide. And that is a fast summary of what happened this legislative session. I'm happy to answer any questions you may have, if there are any.
Questions for Ms. Andrews? You were really a busy person, I can tell you that.
Yes.
And we noted last month of the successes in terms of funding and increasing the salaries of people in public health in Georgia. So that was very welcome.
Yes.
I thought it was interesting. They put a fentanyl testing thing in the middle of a raw milk bill.
Yeah, raw milk was an interesting one. We did testify at both committee hearings and shared the science, the public health concerns and implications of consuming raw milk. But ultimately, it did receive final passage. So we will be watching that one closely.
Thank you, Megan. Dr. Grenzik.
Thank you, Dr. Curran, members of the board. It's a pleasure to be with you this afternoon. I wanted to just take a few minutes and provide a couple of epidemiology updates. One will be our usual brief COVID landscape update, both nationally and in Georgia. And then I wanted to take a few minutes and also talk a little bit about another current event that has public health implications. It happens to also be another virus that's very adept at changing. So we'll talk a little bit about some of the avian influenza situations that are going on here in the United States. So can I have the first slide, please? Thanks so much, Frederick. So first of all, just a brief snapshot of COVID-19, both nationally and here in Georgia. And again, since we met last, I think that the news is even better than it was then. However, we say this with caution, each and every week as we're moving forward. So if we look at the nation as a whole, the COVID case numbers nationally have been generally flat for the last 2 weeks, really at a plateaued level. But the picture is very mixed around the country. We are seeing essentially the Omicron sublineage BA2 increases at about half of all states, particularly in the Northeast. Many states up in the Northeast, such as New Jersey, New York, Rhode Island, are really experiencing case number increases that are greater than 60% from 1 week to the next. But in the rest of the country, we're still seeing case number declines. So again, it's kind of a patchwork of increases due to BA2, but we're not seeing really anywhere in the whole country these surges that are anywhere near what we saw in our previous Omicron BA1 wave. Here in Georgia, our numbers have also been very low and pretty much flat as well over the last few weeks. We are nearly as low case number wise as before we entered the Delta wave, which was the previous wave in 2021. So again, and hospitalizations and deaths here in Georgia have also been on the decline still. They're not plateauing, they're continuing to decrease. And they indeed are a little bit lagging usually to case numbers. So it's really great news. When we look at hospitalizations and deaths, we are really almost as low as we have really ever been in the pandemic. And our national picture looks like that as well. When we look at our sort of landscape as far as vaccination in Georgia goes for our population, we now have 56% of the Georgia population that is fully vaccinated and 23% boosted. And again, that number or that percentage really has only bumped up by 1 percentage point since the last time we talked a month ago. So really, we're still seeing our vaccine numbers decreasing greatly in Georgia. Again, we're really administering very low numbers of vaccines so far since we spoke last. But the importance of vaccination and boostering cannot still be underestimated. When we look at our COVID deaths and hospitalizations here in Georgia, and even though they're at very low levels now compared to earlier in the pandemic, really almost every COVID hospitalization and death has occurred among an individual that has been unvaccinated. Next slide, please. So now, as we typically do, we'll just really quickly run through visually the three main surveillance indicators for our COVID landscape. We'll look at cases, we'll look at hospitalizations and deaths. So first of all, in regards to cases, this is our pandemic epi curve. You've seen it many, many times. And so we are essentially now in the decline of the Omicron wave. And as you can see, really at the far right of the graph, we really are seeing a plateauing, a decline, and then a flattening of our case numbers. Essentially, you will see, sort of one bump up near the far right side of the graph. And again, that is really just a surveillance artifact. It is not a surge. It is not an increase. Our case numbers are very, very low. Our daily totals have been about 400 to 500 cases for the last couple of weeks. So again, we are seeing this flattening of cases, and it has been very consistent over the last few weeks. Next slide, please. And we look at hospitalizations, we're seeing the same pattern. You see the waves of the pandemic and the Omicron wave, which was, this is looking at the daily census of COVID patients in hospitals. And if we look at where we are as of yesterday, again, there were about 370 or so individuals hospitalized with COVID around the entire state. And that is a 93% decrease from kind of the January peak of the Omicron wave. And so again, we are seeing very, very low hospitalization numbers, really as low, if not lower than we have been, even right before Delta, which began last July. So you can see we're on the graph, we're about as low as we have ever been, hospitalization wise. And that is, again, due to a number of factors that even though this BA2 of SARS-CoV-2 variant is very transmissible, it is less severe. It's thought to be less severe, but also this really shows you the overarching impact of vaccination, boostering, and immunity, and in combination as well. That's why, again, not only are our hospitalization numbers very, very low, but the national ones as well. Next slide, please. And here's the third indicator. This is COVID-19 deaths. This also is in decline here in Georgia. Over the last 2 weeks, we've had about a 30% decline. Again, these deaths lag our case declines usually by a few weeks, but again, our number of deaths also is very low and headed down towards, some of our lowest levels as well. We haven't quite reached, sort of that lowest level before Delta, but we will likely get there, in the coming weeks as well. So again, as we just, summarize, the severe outcomes of SARS-CoV-2 infection now really are, again, being limited greatly by the impact of immunity, both natural and vaccine plus booster. Next slide, please. As we have done, we're going to put the three surveillance indicators together just so you can see the red bars are cases, the blue line hospitalization counts, and the green are deaths. So as we can see, as has been true of earlier in the pandemic, our hospitalization and death counts are very, very low, and our case numbers are really dropping as well. Even so, we're not seeing this huge decoupling of hospitalizations and deaths relative to this huge spike of Omicron BA1 this is much more of a ripple than a wave as we see in this particular graph. Next slide, please. And I also wanted to show you again one of the reasons that one of the drivers of the reduction in this severe outcomes really are vaccination and boosting. And I wanted to show you these graphs just to show you that if you look at the upper left-hand corner, this really just shows you, as we all can appreciate, that our vaccine numbers have really been flat in Georgia over a long period of time now. But even so, with again, 56% of individuals that are fully vaccinated and 23% with a booster, look at the impact that it has on these surveillance indicators. The upper right are cases, and if you look at that very bottom line, the gray line, look at how low the case numbers are among individuals that have had a primary series and a booster relative to the black line, which are the unvaccinated, and the red line, which are individuals that have just had the primary vaccine series alone, which helps for sure. But look at what the booster can do. Lower left, these are the other indicators. Really, we're seeing the same picture. The lower left, those are hospitalizations, and the lower right are deaths. And again, we're seeing this tremendous impact of having a primary vaccine series and a booster in that gray line that drops these numbers. down so dramatically from individuals that have not had a vaccine, or even those who have not had a booster. So the message still remains, even though we may be experiencing low case numbers and really just a ripple with BA2, at least here in Georgia, the impact of a booster is tremendous, and we should continue to promote that. Next slide, please. So in summary for our COVID landscape, again, as we've hit on most of these points already, so we have the Omicron surge from December and January and part of February has indeed retreated, but the Omicron sublineage BA2 is increasing in circulation here in Georgia and around the nation. It is now predominant. It's the predominant circulating SARS-CoV-2 virus. It accounts for about 72% of cases nationally and 60% here in Georgia. But again, we are not seeing increases in the severe outcomes, hospitalizations and deaths, and we are not seeing large surges anywhere like we saw with Omicron BA1. Even though there are states around the country experiencing increases, their severe outcomes are also low as well. Again, impact of vaccination and boosters. So all of this indeed, looks like good news, and indeed is good news, particularly relative to other waves in this pandemic. But as you've heard me say many times before, we cannot be complacent. This virus, SARS-CoV-2, is still with us. It will not be eliminated. It has proven very adept at changing, and it certainly has myriad opportunities to do so with the number of individuals that are still or under vaccinated or immune compromised as well, where the virus has an opportunity to infect an individual and then develop and evolve changes or mutations that may result in the emergence of a new variant that might be more severe, might be even more transmissible, or might be able to escape the immune protection afforded by vaccination, boostering, or even previous natural infection. So no matter what, when we think about that, as we're facing it, we realize that still the tools in our toolbox, in our arsenal to protect us as a population still include vaccination, boosters, very, very important, and surveillance, really being able to monitor what's going on virologically, what the viruses look like, where the cases are, the usual epidemiologic principles, and continuing testing. We have to be able to test individuals so that indeed we can do surveillance on viruses to know what's spreading, what's emerging over time. So we will, it's not an if, but a when we face other variants that emerge, we may result in other surges, again, similar to another virus that we know and love very well that I'm going to talk about next. So next slide. Speaking of no complacency, we have a lot of experience and practice with a virus that loves to change and mutate as well, and has been with us for forever, really. And we're talking about influenza viruses. And I'm just going to really briefly talk about influenza viruses because, again, this is another one, like SARS-CoV-2, that loves to change. And usually when we're talking about flu viruses, particularly flu A, normally they circulate in animal or human reservoirs, and they basically stay where they're supposed to in their given reservoir. For example, there are human flu viruses, there are swine flu viruses, and there are avian flu viruses as well. And they're all named according to really the surface proteins on the virus. So they have another combinations of H and N names. So example, human flu viruses, ones that we see every year seasonally, like H3N2 or H1N1. Swine viruses are usually H1s, H2s or H3s, and bird flu viruses are usually, 5, 7s, 9s. and in various combinations. We want flu viruses to stay and circulate within their reservoirs. We don't want them to cross over into other species. But as we see with many, many other viruses, likely SARS-CoV-2 as well, the origin is often an animal species, and we get crossover into humans. And then and there is where we in public health and our partners are concerned, because once it crosses over into a human, that's when we can get those changes and the evolution and the mutations in the flu virus, just like we talked about with SARS-CoV-2 as well. So next slide, please. So any animal flu virus that develops that ability to infect people can evolve and spread and result in a pandemic. So again, the very first time in 2009 that we saw H1N1 from people, it was a novel flu virus. But again, very often we have examples of animal or bird flu viruses that cross over into people. And this again becomes an issue for us in public health, because we want to monitor how the virus is changing once they get into people. So we're going to really just give a couple of examples, and then I'm going to talk a little bit about what is called highly pathogenic avian influenza, and that's what's going on now over the last few months in birds here in the U.S., not in people, and hopefully not ever in people. So again, highly pathogenic avian influenza, we'll call it HPAI, normally is found in wild waterfowl, wild ducks, and other waterfowl. It doesn't even make them sick, they just carry it. And then it can often get transmitted to commercial birds or bird flocks like turkeys or chickens, that are being raised as food animals. If indeed we see this transfer to people, then again, it doesn't belong there in the first place. It could change and evolve, so we want to be able to monitor that. We've had a lot of experience with other flu viruses that have crossed the line into people. In China, since 2003, there have been outbreaks of avian influenza in people as well, of varying types over the years. And over the last few years here in the US, we've even seen swine flu viruses cross into and infect people at some agricultural fairs, primarily in the Midwest. So it can happen, but it's never resulted in this sustained transmission or change where we've gotten a brand new virus, but that's what we keep an eye on. So besides our concern that it could result in a pandemic, the other concern clearly is economic when it comes to agriculture, agribusiness, and food animals. There's a huge economic impact because once, again, for example, once avian influenza can transmit from a wild bird into a commercial chicken flock, it is a huge economic impact because these individuals, these birds get really, really sick and die, and then the rest of the whole flock is usually what is called depopulated or culled to prevent further transmission. Next slide, please. So what's going on right now? You've heard about avian influenza in the US. And again, think about, so far, this is strictly, again, a bird issue right now, but we're keeping a close eye on it because there's a lot of HPAI detections going on in both commercial and backyard flocks in many different states since January of this year. The U.S. has a really strong surveillance program in birds. So you wonder, how do we even find out where bird flu is? The USDA has an intensive surveillance program where they sample both wild birds and commercial flocks as well. And now we've seen so far since January about 160 flocks infected in 26 different states. And 104 of them were commercial flocks, like poultry flocks or turkey flocks. 24 million chickens and turkeys had to be depopulated so far. And this is, again, a huge, huge economic impact as well. There have been no cases of human infection with these viruses, even among individuals that work with these birds or that have worked on depopulating. But that's what we in public health, that's our role. Our role is to assist in monitoring individuals that may have been exposed to these birds in case these viruses were to be transmitted to people. We have never had a case of human HPAI here in the US, and we hope we don't. Next slide, please. So as I've mentioned, again, we in Georgia have worked for many, many years to prepare for HPAI. Agribusiness is our leading industry here in Georgia, and broilers are the most valuable agricultural asset in our state. Huge, huge industry here. We have actually, this is not new to us. We at DPH have participated with a number of partners and stakeholders over many, many years to prepare for all of the various aspects of avian influenza, both from the agricultural side and for us, speaking as DPH, for the potential human impact as well. So as you can see, there's a number of different partners we've already been working with. Besides us, the state and federal agriculture partners, the Georgia Department of Agriculture, the Georgia Poultry Laboratory Network, the University of Georgia, industry partners, healthcare providers, you name it. But our role, again, and we've done this, is really to be able to identify people that may have been exposed to these birds, either working directly with them or depopulating them if needed. Usually they're, under protection and PPE is appropriate, but we want to be able to monitor them for the development of any flu-like illness and facilitate testing. We want to see, again, is there evidence that this is an H5N1 that has crossed into a person, and be able to monitor any changes in that virus as well. And we use our, set of electronic systems that we've already set up for a number of other diseases as well. So next slide. In closing, we, truly infectious diseases, many of them, this is really a one health issue, both human and zoonotic. All infectious diseases like SARS-CoV-2 and influenza are ever changing, unpredictable, but the key and the reassurance that we all have is that really epidemiology and surveillance is going to form the foundation of our control, both globally, locally, and both animal and human surveillance is really the cornerstone. And we see this evidenced and in operation, both for something which is seemingly so different, like COVID, SARS-CoV-2, and avian influenza, but it's still that same foundation of both of surveillance driving control measures as well, and our piece in One Health. So with that, I'll conclude. Thank you so much for your very kind attention.
Thanks a lot, Sherry. As usual, your tutorial teaches us a lot. Are there any questions from the board members or others? So, of course, Sherry, I'll ask a question. I guess two questions. I'll give you a chance to answer either one or both. First question is, when do you recommend and for whom do you recommend a second booster for COVID? And then the second question is related to what might happen with BA2. It looks not so bad right now. Philadelphia is starting to call for masks indoors, and some of the states in the Northeast that have a higher profile of vaccine coverage than we do seem to be kind of worried about this. So what's going to happen to Omicron BA2 in Georgia, and who should get a second booster and when?
Yeah, thanks for the question, Dr. Curran. I wish I could say with certainty exactly what's going to happen with BA2, but I don't know, just like everything else with this pandemic. However, what we're seeing, as I had mentioned earlier, it's interesting, and this happened in countries in Europe as well that experienced BA2 increases well before us is that it really was a mixture of conditions, in a sense that, again, not every country experienced surges and increases, but it really was, again, some increases occurred, some decreases occurred in some states and some countries. And I think that from what we can take from the data now, which again should drive and inform, sort of how we're answering these questions, is that it doesn't seem like we're going to see a huge surge of BA2. However, we still may see increases even over time. What we're starting to see in regards to some of the data, it is thought that Omicron BA1 infection may afford some cross protection to BA2. Perhaps that is what's going on in some places. Perhaps individuals that have, places that have had more BA1, infections, natural infections in their population may not be experiencing as much of a surge. However, no matter what, it looks like BA2, I think we can safely say, and this is probably the most that I can say, BA2 likely will not approach anywhere near BA1 Omicron type surges. And that is probably true across the board, even in the places in the Northeast that are experiencing some increases. It's not looking like we're ever going to get like we were in BA1. And in regards to the second booster, again, I think that it's very important to, think about the recommendations and the approval for individuals that, again, over the age of 50, individuals that have immune compromise. I think that I certainly wouldn't, sort of say anything against of how the booster is recommended is how I would recommend it. And I think that's the way to go. Boosters really have seemed to be of primary importance so far in regards to as you saw, the impact on hospitalizations and deaths. So I certainly promote that in an ongoing way. So I think that's may not be a completely sufficient answer, but as is true of everything else, the crystal ball, I just don't have it yet. Thanks so much.
Thanks, Sherry. Are there any other questions or comments for Dr.
Resnick? Could
Yes.
you please comment on the antivirals and their effect on the BA2?
Oh, so yeah, and again, I may not be I'm certainly not the subject matter expert on all of the antivirals. I wish Dr. Millman were here to talk a little bit about that. However, I will say that again, there are some of the antiviral treatments again have limited impact against BA2 sublineage, and some of these data are still coming out as well. So I think that it's important at least to pay attention to, some of the information about the potential limitations in their effectiveness in the face of BA2. And what we can do as well, if there's additional information of specifics, I'm certainly happy to get Dr. Millman to send out some additional information for all of us as well, if this isn't enough.
Dr. Drensick, I had a question. As we have seen the COVID cases go down in our community, we have seen an uptick in the flu. Do you have any predictions about the flu season in Georgia?
Yeah, that's absolutely an interesting question, and also one that sort of ties in to what we were talking about in the presentation in general. So I think that clearly this flu season here, the human flu season here in Georgia has indeed it was definitely worse than it was last year, but it really wasn't a very bad flu season. And now we're quite late in the season, so we often do get this kind of last ditch, sort of influenza B bump near the very end of the flu season. So it may be that we're sort of experiencing a typical flu season again. Although, isn't it interesting that in the context of the pandemic, when individuals were indeed, working remotely or in social distancing and masking, again, we had virtually no flu at all. So clearly in the context of that not being entirely the case now, we're certainly going to see more flu. And I expect that probably, next year we'll be back to a regular quote unquote type of flu season. That's another one. We really just, the only thing you can say about a flu season is that you've seen one, right? That one changes all the time too. But those same kind of general prevention messages are truly important, like flu vaccine, just like COVID vaccine. So I think that's, so we shall see how, and having, year-round flu surveillance is really important too, which we do. Kind of being able to monitor flu viruses that are circulating even in the summer. So that's another good way to see if there are any changes.
Do you have any data on the flu vaccine uptake in Georgia compared to last year?
I don't have those data in front of me, but I will get that and be sure that we send that out to everyone as well.
Thank you.
Yeah, thanks for the question. I appreciate it.
Other comments or questions? So thank you, Dr. Drenzik and Ms. Andrews. I believe that Dr. Toomey is still not here. Do you have any other closing comments from the department?
So, Dr. Curran, this is Chris Rustin. I just want to say on behalf of Dr. Toomey, we want to thank the folks, Megan Andrews and her deputy Katie, for all the work that she did this last session. It was an extremely busy session, but I think all in all, the department fared very well budget-wise, as well as some of the initiatives that we were promoting. And so want to provide many thanks to them and all the DPH staff that participated during this legislative session. And I'm sure Megan and Katie both are glad for a little bit of a break until next session. So thank you.
Thanks, Chris. Any other comments for anybody else? Any comments from the board on any topic you wish? I believe we're ready to adjourn somewhat early. Turned into a nice day here in Atlanta. So thanks to everybody, and thanks especially to the
Thank you. Thanks to all the staff.
Thank you very much.
Thank you.